Thank you, sir. Thank you, sir. I think the need for tailor-made sizes would be more felt by pediatricians. So I thought this message should reach them. So Dr. Sanjeev and Suganya are here, and the real need was felt when I had a 6 months old baby who wanted a PD. And any suggestions from them to Georgie sir? Any Sanjeev Gulati, Suganya?
I've used Georgie sir's catheter up to, I think, 5 times I've used it till now for my patients. And they come in very handy. So I have already, every time there is a catheter, which is always there in the drawer. So we don't have to order also. So we just put it in. The most convenient, there are two aspects that I feel very convenient while using sir's catheter is, one is that the price. Of course. So although I come from a private center, not all of our patients are affordable, and we do take care of a lot of patients with cost issues. So, and that one, and it's complete. It's all that another Covidin or any catheter would offer. So everything is there, but at a lesser price. And also, when I've spoken to the executives from the company, they're very open to customizing it for us. So a minimum of 5 or 10 catheters, if you order, they customize it for the size and the number of ports that you want, the length, everything. So it's so I've never felt the need to go. So that is one thing. And sir has also been very, very supportive of our efforts. So whenever we call him and with doubts and with problems, he's been very, very supportive and can't ask for a better mentor. The other problems are and we have been using catheters for AKI patients. So we use a lot of soft PD catheters for AKI patients, and we do not really get the single cuff catheters that frequently. So we either end up using a double cuff catheter, and sometimes we do tunnel it. If I do a percutaneous insertion, we do tunnel it. And sometimes we have also left one of the cuffs out. So that is one thing that most frequently we do in pediatrics. I did see all my colleagues had mentioned about fixing the sheath and the rectus. For some reason, when I do it percutaneously, I've never done that, but I think that's a good practice, so that I've learned. And thank you for all the speakers. There's been loads of learning today. I can't imagine learning so much of PD in a particular session in a short span of time. So thank you. Excellently done, all of you. Thank you.
Yes.
At northwest toward Vasant Kunj exit road. Then.
Hello. Yeah, Bala, I'm audible?
Yes, Sanjay.
Yeah, I think first I must compliment you for this excellent meeting. It's been a great learning experience. Georgie has been an ideal father figure for PD in India. Whatever little experience I gained was also from Toronto, where Bill Balfe put in the first PD catheter and started CAPD in children. And we have been putting the percutaneous catheters, for the short-term PD, but for the chronic PD, the experience is that it is better to do an omentectomy also, because the success rate of the catheter is directly there was a study which showed that if you don't do omentectomy, the failure rate is much higher. So for chronic PD, we depend on our surgeons. But for acute PD, since the time when we were in SCPGI, we have published our data also. We have been, the advantage is that you can, reuse these catheters n number of times for much longer. We have used this percutaneous inserted catheters for up to a period of 3 months without any problem. The other thing to, the size of the catheters is an issue in children. So it depends on the weight of the child. So initially, there used to be a panic. I remember the first time we were putting in, there's no PD catheter, no PD. So there is a neonatal size which is required for up to 3 kgs. But up to 3 to 10 kgs is you require a pediatric size catheter. And interestingly, any child who's more than 10 kgs is suitable for a standard adult catheter. So I've seen this panic, and we didn't have PD catheter, so we didn't start peritoneal dialysis. So obviously the guiding principle is that all the holes of the catheter should be inside the peritoneum, because otherwise the leakage will be there. But this is what I would like everyone to remember. Less than 3 kg is neonatal PD catheter, 3 to 10 is pediatric, more than 10 kg is an adult PD catheter. The other precaution in infants, which is again I took from Sick Kids Toronto, is that a lot of these are in diapers, so it should be directed away from the diaper area. I think these are the only things. And again, I must compliment Georgie for his landmark work, for finally giving us a made in India catheter. Thank you.
Thank you, Sanjay. Now, the preferences in overseas, US, Dr. Kumbar and Dr. Adrian, this percutaneous versus open surgery by surgeons. What is the percentage of each of these procedures in your place?
I first of all want to congratulate all of you all for an excellent presentation, especially Dr. Vishal and Dr. Adil. Phenomenal work. I know you asked me a question, but there were 2 other points I wanted to talk about in ultrasound. Is that okay?
Yes, please.
So I'm just going to go ahead and share my screen. Okay, so we'll just talk about it quickly. Can you all see this?
Yes.
All right. So the only other thing that I would suggest is about adhesions that was not talked about. So many of our patients have had surgeries in the belly. And so one of the beautiful things about using ultrasound is you can pick up adhesions in the belly before you go ahead and place the catheter. That way, if there are adhesions on the left side, you can't put the catheter on that side, you can put it on the other side. And here's a good example. I want to show you what a normal bowel it looks like. So when you breathe, the bowel moves. As you can see, it's moving here beautifully. But here on the other side, I'm going to show you with somebody with adhesions. And you can see he's taking a deep breath. The bowel is not moving. You can see how close the bowel wall is to the rectus muscle as well. So in this patient, you cannot place a catheter here. The other thing I wanted to talk about quickly was locating the artery. Everybody talked about the inferior epigastric artery. So one of the things that I do is I surface mark the vessel just before I place the catheter. And you can see here, I've surface marked it on the belly. So I know when I put my needle on the skin, I know where to avoid immediately. You can see from this diagram here, the vessel is in the midline of the muscle. So either you go on the medial side of the vessel, or you go on the, medial side of the rectus, or the lateral side of the rectus. You are usually safe to place the catheter. The last thing is, the second thing I want to talk about is, many of them talked about saying that, it's not a requirement to do bowel preparation. I do ultrasound guided, and I just feel I feel to avoid complications, I like to give a bowel prep. And the simple reason is right here. You can see how the bowel loop is distended. And so when you give them a bowel prep, the bowel is collapsed. And so it's easy to place the catheter. The last thing is to look at the bladder. The first presenter, Adil, showed the bladder. So many of our patients are ESRD patients. And to minimize the risk of bladder perforation, we pass the Foley catheter in. But one of the things that I have realized is many of the times these people don't make any urine at all. So therefore, it's good to ultrasound the bladder and see if this patient has a collapsed bladder, you don't have a problem. On the other hand, there may be people who are CKD5, who are on diuretics, who may be a diabetic, and the bladder is actually full. And you will ask them, did you pass urine? They said yes, and you think actually the bladder is collapsed. But if you do the ultrasound, you see a distended bladder. These are the people where it makes sense to place the catheter. So that's all I wanted to talk about. Oh, one last thing I can show you here that we also do is something known as a pullback angiogram. And this is for Dr. Vishal, since he's doing fluoro-guided catheter placement. So one of the things that we also do here to minimize the risk of bowel perforation is to do a pullback angiogram. So we put a long 5-French sheath, and you can see here, we're shooting dye, and we're making sure that we're not inside the bowel, and you can see the spidery appearance. And you can see here, I pull back in the next image here, I pull back my sheath back up here and I shoot again. This way I know the wire may have gone through the bowel, but the sheath will not go through the bowel. And if I don't see this spidery appearance, I know I've done something wrong, I need to stop. So I just wanted to add those points for the presentation as well, which I thought was excellent. And coming back to your question now, in the United States, a lot of the surgical trainees are not getting trained in PD catheter. They may do 1 or 2 PD catheters. So you can't expect them when they come out to practice to do great PD catheters at all. And so it is up to us, nephrologists, to take this job and make it part of our own. And so I can tell you for a fact that if I refer somebody for a PD catheter replacement, it is usually a very obese person. There are some complications that are going on, or somebody has adhesions. Like I showed you, if I do a pre-op ultrasound and I find intestinal adhesions, I don't do the procedure. I refer it straight to the surgeon.
Thank you. Thank you, Adrian. Dr. Kumbar, your impressions and ideas?
Absolutely. Thanks, Bala. And thanks, Adrian, for giving those tidbits. It really helps. Just to add on to that, couple of things. It makes sense if you have stool in your bowel, the bowel is much more fixed. Even if there is no adhesions, it is going to be just when you're passing your needle, especially if you're using an 18 gauge sharp needle, and you have a bowel with the stool in right below that area, the needle will pass through. But if the bowel is collapsed, it's much more mobile, it's moving a lot. So even if the needle is entering slowly, and if you're touching, the mobility or the peristaltic motion is set in motion, and the bowel actually slides away from your needle, right? Bowel doesn't want to get injured. So I also believe in doing the bowel prep, and we do full golightly as if like it's a colonoscopy, because the regular stool softener and other things doesn't really do much, because most of these patients already have pre-existing constipations. Some of them may be constipated for half of their life, and so it really takes a lot of bowel prep to get all the stool out. And the second thing is the immediate post procedure catheter malfunction will also be avoided if you have a completely decompressed bowel. And as we know that the constipation is a big problem for the catheter malfunction. The other point that I wanted to make, if you're using the ultrasound guidance, the needle or the sono visualization of the needle is very critical. Not all needles are designed to be in the ultrasound. A case in example, I don't know if you use the varus needle. Varus needle has a sharp tip, and as soon as it enters the peritoneum, a blunt tip comes forward. It's one of the commonest needle which is used by even the surgeons when they want to enter the peritoneum, because of the safety net that it involves. But the varus needle is not sonoechogenic. Okay, so you don't really see the tip of the needle. If you're learning the real-time guided needle insertion into the peritoneum, identifying what kind of a needle you're using and how much sono visualization can you have of the tip of the needle, not the body, not the shaft, not just the tissue displacement when you're making the needle move up and down, is very critical. Because yes, the bowel injury is less than 1%, but that less than 1% is not because the inherent risk is low. It is because of all the safety measures which have been taken to avoid that injury. If not, the injury or the risk will exponentially grow up. Personally, I use the Cook-Hawkins needle. For me, it gives a much better visualization, even though it is not. I mean, I would have preferred the varus. If varus was a little bit more sonoechogenic, I would have used varus than the Cook-Hawkins. Two is, I saw the presentations, it talked about the peel-away sheath and inserting the catheter directly in. If we are doing the fluoroscopy guidance and we have already passed a wire and other things, what we do in our practice is to use a strip glide wire or sometimes we use an Amplatz stiff wire so that it gives you a nice stiffness. You don't even have to use the stylet and other things. You can just pass the catheter over, through the pillowy sheath over the stiff glide wire. It flows in much more smoothly. That just a technical variations. Whatever works is the best technique for that person, right? So just minor variations. I didn't hear about catheter function test post catheter placement. We would be surprised how many times, even though the location looks great on the fluoroscopy, fluoro, we inject the contrast, it looks really good in peritoneum, but when you actually hook up a bag and put in 2 liters and how much you get drained out, you would be surprised about that. So I would suggest, in my practice at least, we give at least about a liter, liter and a half, and allow the fluid to come out easily without doing anything. I must say there is a regional, coming to your question about the utility of percutaneous PD insertion versus surgical in Adrian, where he works, is a university hospital. They have their own access center. Where I work, we share our cath lab with the vascular or the vascular surgery. There is regional practice variations, as you can expect in a big country like India and US. In our situations, the PD catheter, even though it is doable, if you don't own your own center, it's very hard to kind of increase the numbers, because then you have competing procedures, and always something or other will push the PD catheter down. So in our practice, majority of the catheters are being placed by the surgeons. Again, I don't think it's a reflection of the catheter, but it's a process. And as you all have seen, there is always a conflict between different specialties who are doing the same kind of a work. So I live in that kind of an environment, but I would say about 60 to 80% of the procedures of the PD catheters are still being placed by the surgeons in our part of the country compared to Adrian's. But again, if there is any risk, then it is better to be done by surgically. And the omentopexy, I want to make a comment what Sanjeev was mentioning. That is one of the key things which is kind of pushing more and more procedures towards qualified laparoscopic surgeons who can do omentopexy at the same time as PD catheter insertion. And we do see that that kind of a technique is improving the catheter longevity in our practices also. So that's something to keep in mind. I hope someday percutaneously we can do something to this omentum.
I have one more thing. I want to just add about constipation. Just a tip. If you look at it, most of our patients are on calcium channel blockers, calcium channel binders. And the side effect of a calcium-based binder is constipation. And that's why I tell these people will be on a binder, and yet they'll be constipated even though they're having a bowel movement. And that's why I prefer a bowel prep.
Thank you, Kumar. You reminded us that Veress needle. Actually, I was going to ask about Veress needle. You said it's not, ultrasound doesn't really pick it up. I think in the future meeting from Vellore, they often use Veress needle. I think they'll demonstrate for the juniors. Then
I just want to highlight again, it is mandatory that the patient should have an enema given. Because if you don't do that, you will end up in trouble. When I was introducing the catheter in 1986 at Toronto, using the Trocar and cannula, I know that in one of the elderly patients, I punctured the bowel and the catheter went into the bowel. And immediately after infusion of the fluid, the patient started having diarrhea. So what I did was immediately pulled out the catheter, and it was a day procedure, and put the patient on flagyl and gram-negative cover, and nothing happened. So bowel preparation is an absolute must, and it must be taught to the people who are planning to put the catheter.
Dr. Tarun?
Yeah. Yes, sir. About the same. See, let me make a comment. Unfortunately, in my center, predominantly the practices of laparoscopic PD catheter insertion right from the beginning. Last 15 years, I've been doing that. And for the advantage, again, which has been mentioned, that we can fix the catheter, which avoids migration, and do an omentopexy at the same time. And those only catheters, only the reason why we put in a percute catheters are, number one, for financial reasons, because laparoscopic is hugely expensive and somebody who's not covered faces a difficulty. Bedside catheters, we put in percutaneous. So these are some reasons why we put in a percute PD catheters. But most of us, most of my patients are on laparoscopic PD catheter insertion. And I do what all of us have discussed, the bowel prep and the marking and all these things that we do usually. So I have never seen catheter migration. I have never seen with laparoscopic. I have never seen omental wrap also. However, two advantages I would like to mention here. In two of, say, roughly 100 last patients, we were surprised to see significant adhesions inside. And later on, one of these lady patients said that she had a history of tubercular ascites, which was not mentioned earlier. The other was idiopathic. So we had to abandon the procedure as well. So I was wondering if we try to put in a percutaneous PD catheter, we probably might have landed into MES or non-functioning catheter. So that is what my center does right now.
The very purpose of a nephrologist taking up is the cost. And sometimes you can even waive the whole fees, which we can't be asking the surgeon always.
Absolutely.
Yeah. And the straight versus cuffed, the pre-curved. I think as Professor Georgie mentioned, we should always prefer pre-curved, because tendency to straighten and the tip in the pelvis can become, go lateral, and later it can straighten and give problems.
Yeah, so long time back we left straight catheters. Now we are using swan neck only, and we have been finding it quite comfortable. We are comfortable with that swan neck catheters.
Yeah, and as nephrologists start doing more and more of this, they'll get more emboldened and they'll start doing, fixing the inner cuff, then a semi-surgical technique, and later maybe even laparoscopic thing. And I think as Adil wants to, encourage full-time interventional nephrologists. Interventional nephrologists. I think other nephrologists, instead of giving it to surgeons, they can make their interventional nephrology colleague and pass on the case rather sending it to surgeon. Such situation would come over time, I think.
One additional comment, if I make, it's not directly academic, but for me, if I want to put in a percute PD catheter in operation theater, it takes half of the day for logistics. So that also is one of the inhibiting factor to plan for a percute PD catheter in a setup, which is mostly ventured by surgeons and all these things. I get the last kind of a slot and all these things. It takes huge time. And then you are off from your OPDs and then rounds and all these things. It becomes a little logistically difficult as well.
Actually, precisely the need for intervention nephrology is more in mobile areas and 2-tier cities rather than in cities with corporate setup. Actually, rather corporate setup, you are not allowed to enter cath lab or theaters also. So I think it is more relevant, and that is why it is picking up more in lesser areas.
One thing I wanted to add is, when you choose between the two catheters, single cuff versus double cuff, if you have a patient who is immunocompromised, is diabetic, who won't take care of the catheter, it's better to put a double cuff catheter, because that other superficial cuff will prevent the infection. From an interventional standpoint of view, whether to put a straight catheter that is a straight in the belly, in the pelvis, versus a pigtail, that is always a debate. When I've spoken to a lot of our colleagues here in the United States, when you have a dysfunctional catheter and you have fibrin clots sitting in the catheter, it is always easy to clean it out when the catheter is straight, as opposed to a pigtail. A straight catheter can migrate, but the pigtail will stay inside in the pelvis. So it's a choice that whatever you like to do, I think that's what you should do.
As you start putting in more and more catheters, you will reach a stage where, I always fix my inner catheter, inner cuff, and this tunneling, I make another puncture, cephalad, and pull out the catheter out. Then again, turn it down and bring it below. That way, I'm sort of confident that there will be the curve there is enough subcutaneous tissue keeping the curve, and it is not allowing the catheter to straighten out. It may involve another puncture, but I always do that. So from the inner cuff, I go up, bring out the catheter, then again turn down and bring it down. It may sound a little crazy, but I feel confident doing it that way. Because I'm always scared, simply burying the curve inside the subcutaneous area. If the patient starts pulling it, or inadvertent pulling of the catheter can straighten and cause the extrusion of the external cuff. Then again, regarding the distance between the external cuff and the exit site, any comments from the panel? Because there's epithelialization and reaching the cuff.
It should not be less than 2 centimeters from the distal cuff, the exit side, because I have seen in children when they waist, the distal cuff has come and extruded. So cuff extrusion may be a problem, and patients who are overweight, when they lose weight, the cuff can extrude out. So always it is better to have a reasonable distance of 2 centimeters or more than 2 centimeters between the distal cuff and the exit side.
Dr. Velaravan?
Yes, sir. So enough has been said on various techniques, but I agree with you, sir. 2 nick I'll make, sir, the exit side to make a very round curve. I totally agree with you, sir. It makes a very elegant in terms of curve. And the second thing, as sir said, curve, extrusion may not be there, sir. It's a good point, sir. But I'm a man of open techniques, sir. Mini open technique. I've crossed more than 650 catheters. I'm very comfortable. I just go inside, give local anesthesia, sedate the patient, and do it within 20 minutes. And my PD first policy I'm adopting so many patients, like 20 creatinine and 18 creatinine. I just put the catheter and start the dialysis immediately. Even I can put 2 liters inside. That's my way of pursuing sutures are inside. I go inside. It's like a mini surgical technique. So you make a 1-inch incision subnavel, and the beauty of the abdomen is you go inside and pull the entire anterior abdominal outwards. Sir. Even one small incision may, we can do a lot of wonders in that. So I'm very, very comfortable. Over the time I learned crossing 600 catheters. So it's very easy for me, not laparoscopy, percutaneous, because initially I was doing percutaneous, a lot of migration I had. Maybe I'm biased now, but I'm very comfortable with the open techniques, sir. Mini open technique, mini, very, very small open technique.
But beginners may not take it up straight till that.
Yeah, that's very
regarding
difficult.
midline versus paramedian. I somehow am comfortable with the midline, subumbilical, and I fix the inner cuff. So, any comments from others? Of course, the rectus makes it more secure, I know. But if you fix the inner cuff in the midline, there is no botheration of vessels and bleeding,
Dr. Bala?
Yeah.
This is Narayan Prasad. Can I comment on this?
Please, yeah, I was going to call you. Yeah, I know. Yes.
Actually, in my institution and whatever I would do, I used to put this midline incision. I have never done paramedian because for the learner and those who do not have any ultrasonogram, those who do not have any fluoroscopic things, go this avascular area, linea alba, midline incision, about 2.5 centimeter below this umbilicus, and this is the most avascular plane where you do not have the chance of the bleeding and any. And if you have the opportunity, you can fix this internal cuff, even if you are not doing, and if you have the break-in period of the 10 or 14 days, then everything would be fibrosed. But you have to take care of whether there should not be any pull for the 10 or 14 days of this break-in period. So I think that will give you the least vascular complications, particularly those who are working in the remote places where they are putting the first time the percutaneous catheter insertion. bleeding from any angle, any injury to this inferior epigastric or any other arterial bleeding is, then they will get demoralized. It's very difficult to control that bleeding also.
Yeah, once bitten, twice shy. So initial complication will put people off. But
And I have never done any, now we have stopped doing this internal cuff fixation also. Just we take care that there should not be any pulling kind of things for 10, 14 days. And everything gets fibrosis. This is all the healing will happen with the fibrosis, and there will not be anything after 10 or 14 days of this period. So, and then one thing about the straight versus coiled catheter that we are talking about. But when you go about the any randomized control trial of the straight versus curved catheter, there is no definite conclusion about this coiled catheter is better than this straight catheter. And I think a straight catheter is easier to put in. And definitely it varies from experience, might vary from the different center. But recently I was reviewing one of the randomized control trial from Singapore for the publication. And then we have reviewed everything. It is looking like there is no at all any benefit of this coiled over this straight catheter. Straight catheter is equally good, but double cuff is usually preferred. And double cuff straight catheter is as good as any other catheter.
Only situation I use straight catheter double cuff is in small built persons or children especially. So I put in the catheter on one side and curve it above the umbilicus and bring it to the other side, the exit side. So that way, that is the situation I always use straight catheter. But all otherwise, in future meetings, we'll start demonstrating use of Veress needle and fixing the catheter, tunneling, small bits we'll demonstrate to facilitate the juniors to learn.
Agreed. Thank you, Dr. Over to you.
And any?
Somebody has asked how to diagnose adhesions, beforehand,
Yeah, Dr. Adil or Adrian can, they elegantly showed the ultrasound. Any more thing to add? They want to know how you can, any other imaging techniques other than ultrasound, MRI, things like that.
Well, if you start
when
doing,
you are in doubt.
You start doing MRI and all, then the cost of the procedure is phenomenal.
No, when you are in doubt and complicated cases, you don't want to.
So let me ask you, people to get an MRI or get the surgeon to put the catheter in India?
No, I'm asking like they want to know how can you be sure of no adhesions in suspected cases?
No, then in suspected case, you probably have to get a CAT scan or you have to do a barium swallow and check. That's the only other way. Stop short of going and looking straight inside the belly by doing a laparoscopy. And so my whole point is if you feel that the history is telling you and the ultrasound is suggestive, it is better to send to the surgeon because he can diagnose and fix it at the same time for you.
And if I may add on, I agree with Adrian. So I go by history most. If they have prior history of any surgeries, if it's just a simple cholecystectomy, simple appendectomy, it's okay. But if they had a complicated cholecystitis or an abscess, or if they had multiple C-sections, or any of where the peritoneum was breached prior, and it was a complicated recovery, those automatically I kind of send them to the surgeons. Most of the time, the surgeons will make a decision on putting PD catheters without any imaging, depending upon the level of surgical history. If they feel that they had a bad prior surgery, it's not really worth it to go and look for all these adhesions. They might not even attempt putting a catheter. If not, as Adrian was mentioning, a CAT scan is our kind of preferred one. It helps to identify the adhesions much better, and it is pretty quick. Cost is a little bit less compared to the MRI. MRI getting in a whole abdomen and pelvis is much more exponentially costly than a CAT scan, simple CAT scan. But I agree with Adrian. it's the history that makes us to go towards the surgery.
Then talking about midline, Narayan Prasad, one situation I find the problem in midline is in obese patients, their pre-pelvic space, pre-peritoneal space is quite significant in them. Actually, Adil ultrasound, he showed the small area and mentioned it as pre-peritoneal space in the midline. If that is roomy, and if you are not careful, your guide wire can go and comfortably, make a coil there and give you a false feeling that you are inside the peritoneum. So it is always a good idea to put in the dye and see. So because the dye will, get restricted to the pre-peritoneal space. So this happens in midline in obese patients, subumbilical.
So we had a similar case like that, and we wrote a paper up in HAKD where using fluoroscopy, when you shoot the dye, looking at how the dye looks inside the pre-peritoneal space, you can tell whether it's inside the belly or outside of the peritoneal cavity. So those initial cine shots are so important because we just glance through it sometimes, but we missed a case just from that. And when we went back, we noticed, oh, look at the signature of the contrast. How does it look in the pre-peritoneal cavity? So we wrote up a case. It's in HAKD. If you all are interested, and the whole point there was why is it so important to do fluoroscopy, shoot dye before you pass anything into the belly.
But again, nephrologists taking up interventions, my advice and mantra is always to equip yourself with facilities. Don't take risks doing blind, and we may get into trouble, then you may have to call the surgeon. So try to have C-arm, try to have ultrasound, and I think that would be safer.
Sir, one practical point, sir. Sometimes in nephrology, they put a catheter, they connect to automated peritoneal dialysis machine for a few days, for initial uremia to come down. Successfully, they'll implant a catheter, flow will be good. 2 days later, they find that flow, inflow may not be there and outflow will be very difficult. This is a typical momental wrapping because machine sucks at the end of the cycle. This momental, all the pores will be occluded by momentum. This is a common thing. I've seen 2 patients here. So on table flow is good. 2 days patient was doing well on an APD machine, and 3rd day there's no flow. And catheter position is a normal left iliac fossa, but this is the typical. So the clinical point is when the flow is going in and outflow is not there, it is a migration. If the inflow is not good and outflow is not good, mostly momental happens. So there's no meddling with the patient. You have to intervene quickly. This is a very good clinical point we can. So whenever you connect a patient to APD in the initial phase, so because the abdomen is very naive and the momentum is not that much trained to the, so it will get sucked to the, all the holes will be filled in. So recently we had one of our patients. So this is a very good practical point. So we need not confuse many things. So this is a momental wrapping, simple point.
Yeah, and typically momentum will require some time to search and get the wrap around. So it may not happen immediately. Then one last point, which pelvis, like left iliac fossa or the right iliac fossa, which should you try to put the tip? Is there any preference, left versus right? Because somebody gave me a reasoning that, see, your sigmoid colon peristalsis is going downwards, whereas right side, your peristalsis is upwards. So it is better to put it on the left side. Is there any rationale in that?
That's what I was told as well, but I put it on either side. It doesn't matter, in my opinion, because you can't figure out all of these things, So I don't have any preference. I've been taught the same thing. But
I try putting it on the left side, but sometimes guide wire goes to the right and curves. Then I don't try to change it actively.
Even I do place on the left side, sir. But when the patient is semi-conscious, we don't give anesthesia, only locally are doing. The moment you place the catheter, patient will have some kind of a very strange sensation in the anus. That means that you are in the left iliac fossa. It's one way you can judge instead of going for all the hi-fi gadgets. You can always patient will quickly say that, no, sir, I'm having some kind of sensation in the anus. That means you are in the left iliac fossa. I'm putting all catheters on left iliac fossa, as you said, sir. And I'm very comfortable. There's no migration, nothing.
That's wonderful, because we don't do loco. We put everything under moderate sedation, so the patient is out. So I can't even go by that feeling where you say, hey, because like you say, bladder sensation or sensation over the anus. Our patients are out.
That's a good clinical point we observed on our patients. That's
Dr. Gopalakrishnan, are you there?
Yes, sir.
Yeah, Gopal, now with the government trying to encourage PD, I think there should be a lot of role for government departments to train the students for PD catheter placement, right?
Yeah, that's true. I think is that now government of Tamil Nadu has initiated a lot of programs to improve renal health, and I've been nominated as a state nodal officer for renal health. The mandate that has been given to me is plan, strategize, and facilitate the implementation of various programs, starting from prevention, health education on, renal health education, campaign on adequate water consumption, incorporation of renal health in high school curriculum, and so on and so forth, and hotspot, CKD hotspot identification, and cluster survey to assess the prevalence of CKD, and measures to retard the progression of CKD, AKI survivor screening, and also CAPD. Now the government is focusing to emphasize on the need for promoting CAPD as a viable alternative for hemodialysis. One trigger for such an important decision of the government to go more towards CAPD was in many parts of, it didn't happen in Chennai, particularly in our institution, but in any remote areas of Tamil Nadu, during the current pandemic, particularly during the first wave, many patients could not reach dialysis, and many dialysis centers were shut, and the patients were put into a lot of trouble. And that was the trigger point to think more towards the CAPD kind of. I have been a proponent of CAPD for quite some time, but it didn't happen due to multiple reasons. Whenever we reach a zenith of number of beneficiaries, some problem will set in, and again we'll go back to square one. But now with the renewed interest of the government and the bureaucracy, even the politicians, I think we are going to make a big change in the of renal replacement therapy towards CAPD. That is number one. And you might have heard about the recent government program, Makkali Thedi Maruthuvam, in the sense that the antihypertensives and antidiabetics will be delivered at home, even in the remote rural pockets, to mitigate the problem of, to ensure a better BP control and sugar control. In addition to these drugs, CAPD bags also have been included. And Dr. Balasubramaniam, Professor of Nephrology, KMC, Kilpatrick Medical College, is a state nodal officer for CAPD. So we work together. Along with me, Dr. Manurajan is there, and a couple of senior residents are also going to be part of our team. And already we have started issuing CAPD bags at home itself. That's a big thing. And we are just strategizing the CAPD care delivery program. We feel that it's enough if the patient is reviewed by the nephrologist once in 2 months. The PD coordinator will reach home and monitor the patient, and such coordinators are given training about the complete program, the basic knowledge, implementation, execution, and so on. The red flags when the system should get alerted and so on. A lot of things are happening. Once the program takes a robust shape, I'll be glad to, myself and Dr. Balasubramanian will be glad to share what we are devising about. This is number one. Number two, even though I'm not against the interventional nephrology, but I always hold the view that interventional nephrology should be an add-on skill of the nephrologist. Interventional nephrology should not be at the cost of basic core nephrology. I'm reminded of this basic dictum, and I keep telling my students that way. And most of the trainees, they are already very well versed with the CAPD catheter placement. For instance, during the past couple of months, we have put on about 12 CAPD catheter insertions. And particularly for the last 2 batches, which they have left our department, they are very well versed. Our middle level consultants, at least 2-3 of them are very good, and they're able to train our candidates in a nice way. Thank you.
It was good news. So if there aren't any more thing to add, I think I'm glad this time it was a very great learning from so many inputs from different panelists and participants. I thank everybody who spared time to join us, and I wish from here on we go to greater heights and involve more and more people. And I need suggestions to the WhatsApp group or the website, and any new area which you have innovated, you want to demonstrate, you feel free to write to me. And it need not be 30 minutes, 40 minutes. It can be 5 minutes, 10 minutes, small innovations, changes, or problems you came across. To put it up. Thank you, all the panelists and all the participants.
That's such a wonderful academic feast. It was so good. And as I already mentioned, all the nephrologists working in government institutions will be too keen to learn more and more about the nuances and intricacies of CAPD. Thank you so much, and my heart congratulations to all the speakers. And always, we are all indebted to the father of CAPD in India, Dr. Jaji sir.
Thank you. Thank you then. I think if nothing more, we'll call it a day. And good night, everybody.